I was born and raised in California, went to Stanford as an undergraduate, Harvard Medical School, Harvard psychiatric training, research training at the intramural program of the National Institute of Mental Health in Bethesda, fellowship in London for a year after that, assistant professor of psychiatry at Yale for a year, returned to Washington, D.C. area where I was the first chief of the Center for Studies of Schizophrenia as a National Institute of Mental Health. I did a lot of different things there, but the one sort of lasting contribution is the Schizophrenia Bulletin, which is a world-class journal, and I think in the citations index for psychiatry, it's the third most cited journal now, something like that. So it's quite a prestigious journal, and I basically started it and was its first editor-in-chief. I did the Satiric project, for which I am well known, while I was at the National Institute of Mental Health. And basically, the project was in Palo Alto, and I was in Washington. And I did a lot of telephone and airplane work on that project. In 1980, I went to Italy for almost a year to study their new law governing the whole mental health system, a nationwide law that was quite radical by some people's standards, not by others. And I went to see how well it was being implemented, because it was a radical change. From there, I was a full-time professor at the Uniformed Services University of the Health Sciences in Bethesda. When I left there, because I retired from the public health service, I became the clinical director in Montgomery County, Maryland, which is right adjacent to Washington, D.C. It's used to be a bedroom town. Now it's got its own sort of industrial base as well. And was there for 8 years, and created quite a good system of a very good system of public care. And I was then recruited because San Diego thought they wanted to reform their system. I think that was a wish on some people's part, but not the people who really counted. And so after a couple of years, I decided that I was wasting my time working for San Diego County, so I resigned. And since then, I've been doing Soteria Associates, which is a consulting company. I see clients, I see families, I do a lot of email work. I travel to give lectures and seminars and so forth. And I am a clinical professor of psychiatry at UCSD. I guess that brings me up to date. I did the Satiric project, for which I am well known, while I was at the National Institute of Mental Health. Satiric was an experiment that we did for 12 years, based in Palo Alto, but we had two facilities, one in San Jose and one in San Mateo, where we took in people who were young, newly diagnosed as having something called schizophrenia, whatever that is, and there we treated them in a special social environment, staffed by non-professionals, supervised by professionals, but the basic staffing were not non-professionals. and we treated them without neuroleptic drugs as much as we could, which was the vast majority had no neuroleptics for the first 6 weeks. And we compared them with a randomized control group that got what we called, quote, usual treatment on the wards of general hospitals in these two communities. You know, it turned out that the vast majority of the people who went through the experimental programs got better within the first 6 weeks without medications. Some did not, of course, but most did. And if you looked at change between admission and 6 weeks for the two groups, the experimental and the control group, the amount of change was almost exactly the same. Change in level of psychopathology, that is symptoms, were similar, but the difference was that almost none of the soteria or experimental group folks had neuroleptics, whereas all of the control group had neuroleptic treatment. This even surprised us because we thought that a psychosocial approach would take more time than the drugs would. And so finding comparable decreases in levels of symptoms at 6 weeks is quite surprising for us too. But it's so, it happened. And then we followed them for a total of 2 years, both groups. And at 2 years, the soteria group as a whole was doing significantly better than the control group. The soteria group who were thought, the part of the soteria group that was thought to have the worst long-term outcomes, that is predicted to have the worst long-term outcomes, actually turned out to be gain the most from that kind of a program because they were really much better than the comparable group among the controls, which was, again, one of the reasons for starting the program was to try and deal with the people who were sort of headed for long-term careers as disabled persons, you know, on SSI, whatever, and to try something experimental on the worst cases, not the best, because if you can affect the worst cases, you've really done yourself a favor. And we did, and they were really the strongest difference was between them and the controls, more than the overall group. The third finding was 43% of the experimentally treated subjects never received neuroleptics during the entire 2 years. And that 43% was also doing dramatically better than the folks who had received neuroleptic drugs. As you can tell, or maybe you can't tell, but as you might expect, these kinds of findings are not, they fly in the face of all of the conventional wisdom about the treatment of schizophrenia. And so the project was controversial, to say the least, marginalized, and was treated as an experiment, as if never done by American psychiatry. If you look in these big reviews of treatment of schizophrenia and stuff, the 2 or 3 biggest ones don't even have a reference to the project, despite the fact when they were written there were on the order of 35 papers in the literature about it. So it's not like, you know, oh gee, we missed it. You know, that was a very conscious choice. And actually, I saw some of those reviews. They sent to me, and I said, how can you not at least mention the results of the soteria project? And that didn't change their mind about not mentioning the results. So you won't find it in the standard sort of guidelines for the treatment of schizophrenia books that are around. So that just tells you how American psychiatry feels about a non-psychopharmacological approach to schizophrenia. That they just don't think it's worth even considering. And with, of course, the aiding and abetting of that point of view by the pharmaceutical companies, you know, who have more money than Job, and they're happy to spread it around so that everybody is drugged and hardly anybody gets talked to. The American Psychiatric Association has really just become the American Psycho-Pharmacological Association. Today, as we speak, in San Diego, if you admit an acutely psychotic person to a hospital here and you don't treat him or her immediately with the neuroleptics, you could well be sued for malpractice. So that's how bad it's gotten in terms of the way this problem, whatever schizophrenia is approached now. And I don't know if you saw it or not, but I wrote a rather famous or maybe infamous letter of resignation from the American Psychiatric Association in 1998 because I felt they had become just a branch of the pharmaceutical industry and were really pretty much under its thumb. It gets complicated because what I used to say was that the National Institute of Mental Health, which is public money, should spend its money on things that the drug companies won't research and just leave all the drug research to the drug companies. But it turns out that the drug companies design studies that are make, how do I put this? They are designed in a way to maximize the possibility that the drugs will turn out to be safe and effective, which is what the FDA wants. So somebody has got to sort of watch over the kind of studies they're doing, the interpretations they make of them, the ones they don't publish. For example, they don't publish studies that aren't positive, that they're in somebody's drawer somewhere. They ghostwrite studies, and so it's not exactly it's not an industry that can live without scrutiny and expect the drugs that come out to be not harmful. They really need a lot more scrutiny than they get at the moment. You know, it's gotten so that it's hard to find people to do reviews of drugs who do not have a conflict of interest. That is, there is hardly anyone who knows enough about the drugs to do a review of them who is not on the payroll of one of the drug companies. So, you know, so conflict of interest is just everywhere. I was at my doctor the other morning, and I mean, the drug reps were lined up in the office with their little pull-along suitcases, and there were 3 there as I got off the elevator. 3 got off the elevator with me, and they are in there, you know, and it's incredible. And so you know, every doctor has closets full of free samples. They're paying for all the research that's being done on the drug. Not all, but the vast majority of the research. They have an enormous number of people who serve as consultants, advisors, lecturers, and so forth, that they pay very well for doing not all that much. And it's a, it's really a pervasive sort of, I don't know, perversion of the field, I think. They also give money to the grassroots, so-called grassroots groups, like the Anxiety Disorders Association, like the National Alliance for the Mentally Ill, like the one for kids, CHADD, C-H-A-D-D. All these organizations which are said to be sort of grassroots, that means people involved in it, are all supported by the drug companies, you know. And, you know, so what's their position on such things? Drugs are the answer. So that's a very sad state of affairs. There's no black box on the warning that says this may cause some percentage of patients given it to become suicidal. They have not put that label on. They've sent out cautionary notes, but never anything very strong. Now with kids, they're getting around to putting stronger warnings on, I think. They will. And as a matter of fact, in the UK, they've basically banned the use of drugs like Paxil and Zoloft and so forth with anybody under 18 because of the studies that show that they're A, not effective, and B, have this effect of causing some people to become suicidal and or homicidal who had never been. The other thing is that I forgot the last count, but most of the school shooters, the school shooters, were on one or another of these antidepressants when they did the shooting. And now when I read a newspaper report that says employee walks into the factory and shoots 5 fellow employees, and everybody says, oh, John was such a meek, mild-mannered guy. He never had been violent in his life. He never did anything like that. And you hear those reports, I say, I'll bet you he had either just started one of the SSRIs or had just increased his dose or had just stopped it. And if you go to those cases, you'll find that's very often the truth. But they've successfully, for what, Prozac came out in 1987, so how many years is it? That's 13, 17 years. So for 17 years, those drugs have been out there with that side effect, or adverse effect, not side effect, adverse effect. And David Healy, who knows more about that than anybody in the world, he estimates that 50,000 people have killed themselves because of those drugs, and 500,000 have made suicide attempts because of those drugs. It is very clear that psychiatrists have become mostly prescription writers. That's what they do for a living now. And if you want to become a psychiatrist, that's pretty much what you're going to do. I really have come more and more to believe that the medicalization of human distress is often more destructive than constructive. And so the advice is generally to try and solve the problem, whatever the problem is, and remember, I'm not talking about a diagnosis. I'm talking about a problem. And that's, I have no issue with people saying I have this problem, but I do have an issue with people coming and say I am depressed. Well, what are you depressed about? I mean, what's the problem? Okay, and my advice is generally to try and solve the problem in the context of your family or social network, your normal environment. And that if you're going to go down the pathway of finding treatment, to find treatment which is most normalizing, that is most sort of keeps you in your regular life as much as possible, is based on your own context, that is your particular unique story, your narrative, the way your life has gone. So that's the context, and one which preserves as much as possible your power, and that is by you finding the solutions to the problem. Maybe I, as a therapist, will sort of ask questions which may direct you to them, but they're your solutions, and so therefore you feel like you are curing yourself. I am not waving a wand and suddenly everything is fixed, but it's rather it's your problem and your solution. I know a lot of people who swear by the various psychotropic drugs, I mean, as having been helpful, and I'm certain that's true. But when you want to just be sure that if you're going to take something, you want to know as much about it as you possibly can, because most people accept doctors' authority sort of unquestionably, without question. And so, I say, here, take these, twice a day and call me in 2 weeks or whatever. And that's not enough, it's much more is, I would say it much more like, now, some people have found these pills, whatever it is, to be helpful. And I'm going to start you on so much of them, and I want you to keep a diary as to what effect they have on the problem, which we already have defined. And I say, then I will say, if any of the following things happen, and then I'll list sort of the commonest adverse effects, stop taking the drug and call me immediately, because I want to know about it. And then we'll see where we go from there. And it's the part of really getting people's informed consent about the drug. And that means that, and that's not just signing a piece of paper, that's easy, but really knowing what it is the drug is supposed to do and what its adverse consequences might be, so that they can recognize them. So as you can tell, I'm not much of a believer in drugs for depression. The people that I see with depression, if possible, I see them with their families or their wives, if they're married. I do sort of holistic care, attending to their diet, their exercise, their ability to relieve stress. So I teach meditation and stuff like that, and I get people working out, and I tell them to try to eat a good diet and all those good things. And the people who come here, what I do is I wean them off the drugs they're on, and then we talk about why they are depressed, what that's about. And it's usually not terribly mysterious, you know. I mean, something has gone on that is stuck in their psychological craw and needs to be, you know, sort of opened up and looked at. And or I like to think of it as when you get a splinter under your finger, until you pull it out, it's going to fester. But if you pull it out, it won't fester. So that's sort of the approach: is what was it that made you depressed, and what can we do to sort that out? And you know, I may use something to help people sleep, because I think it's important to sleep. You know, you can get pretty screwed up just by not sleeping, and as most college students can testify to. But other than that, I pretty much steer clear of any drug treatment. It's very hard to characterize it because it varies so much across people. You know, with some people, I do something that is very much like cognitive behavioral therapy. With some people, I do that, and especially people who are task-oriented and who like to be in control and stuff like that. But there are people who, like one, I remember a couple I saw, and the problem was that the husband's brother had committed suicide some years before, and that he had never really mourned the loss of his brother because the family was sort of ashamed and it couldn't be talked about, blah, blah, blah. And once we talked about his brother for, I don't know, 3 or 4 sessions, you know, he got enormously better just by being able to sort of talk about it. It's funny, as you work with people, you learn what kind of things seem to work. And techniques like focusing on what happened, and then focusing on all of the negative thoughts and how to get those negative thoughts away, giving homework, you know, things to do, tasks to do at home, and all that stuff are elements of cognitive behavioral therapy. But in fact, I send some people to real cognitive behavioral therapists because I think they have a specific technique which has been shown to work. And mine is much more ad hoc and less specific than what they do. And so, but I'll send people to them, and I might continue to see the person, you know, from time to time.